for gallbladder disease. Cholelithiasis. I'm sure you guys heard about this, right? This is gallstone disease, okay? So about a million new cases happen a year in the United States. Half of them require surgery. It's very common to do the surgery on this, to remove the gallbladder. Good thing about this, the mortality rate is less than 1%. So this is a reassurance if you know anyone that has gallbladder disease and there's an avenue that they are saying that you should go for surgery. All right, if you tell them it's less than 1% mortality rate, you might push them a little bit. But anyway, gallstone content. What actually is inside the gallstones? It's usually 80%. They usually have cholesterol because cholesterol is needed for bile. So it's loaded with cholesterol in the area over there, and that's what they're mostly made of. We also have bilirubin. So you could also have about 20% of them start building up because of bilirubin, pigments. All right, but mostly it's cholesterol. So the risk factors, we should say the 4 F's. All right, female, 40, fat, and fertile. Okay, if you see someone who is epigastric pain, all right, or some kind of pain in the abdomen, and it's a female, she's about 38, 40 years old, she's fertile, in other words, she's still got her ovaries, right? She has estrogen on board, and she's not the skinniest one there. You put that together, chances are that's what she has, okay? All right. Oral contraceptive. An oral contraceptive pill, what that does is that it increases cholesterol uptake and secretion by the liver. So we won't go too much into estrogen buildup, all right, because it's more oral contraceptive is more like pharmacology. But anything, if you have a lot of estrogen, that's why we're saying fertile, okay? If you have a lot of estrogen on board, then that's going to have the liver sequester more cholesterol and build more, well, bile and stuff, all right? A lot of, with that. So there's a greater chance that if there's more cholesterol in the gallbladder, that can turn into gallstones, all right? The other thing is pregnancy. Pregnancy, we also have progesterone buildup. Progesterone is going to decrease the gallbladder motility. I use GB quite often in this PowerPoint, that's gallbladder. So it's going to slow that. Now, one thing I want to say about progesterone, and pregnancy for that matter, progesterone is known as the pregnancy hormone. But it's not just there. I mean, as you know from A&P2, progesterone also appears 2 weeks after ovulation. And then it goes down once the menstruation occurs. But during pregnancy, it's all over there. It stays high throughout the whole pregnancy because it keeps the pregnancy going, keeps the placenta going and stuff. So we'll get into that later. But what progesterone also does is that it actually slows down the contractions of smooth muscle throughout the whole body. So keep this in mind. Where smooth muscle is located? Smooth muscle is in the stomach. So it's going to slow the stomach. Smooth muscles around the intestines. It's going to slow the intestines, including the colon. So if you slow the food moving in the colon, the peristalsis, there's more constipation that happens in pregnancy. Right? Putting that together. All right? The food in the stomach is going to stay longer in the stomach. Normally for you and I, it'll stay in the stomach for about 3 to 4 hours. In a pregnant woman, it'll stay there for about 8 hours or more. So that's why it's important. What we usually tell people, or what we know as a little cliche thing, that every woman who's pregnant, her stomach's always full. So if they have to do any kind of surgery, we're always making precautions that that stomach is full. Even if you ate, let's say, 8 hours ago, there's probably something left in there because it's slow. You keep this in mind as we get into the female reproductive system. All right? Progesterone does this during pregnancy. The other thing is the ureters, right? You got your kidneys and you got your urinary bladder. But the tubes, the 12-inch tubes that lead from the kidney to the urinary bladder, how does the urine move down from the kidneys to the urinary bladder? Peristalsis. There's smooth muscles around it. So they're not going to be moving as much. So it's not unlikely that they're going to be dilated. This will also keep more urine in the ureters, which means that that's a wonderful medium that bacteria love to grow in. So if you have bacteria in the urinary, and this is, let's say, for a pregnant woman, if you have bacteria that's sitting in the vagina, it can go right into the urinary bladder, set camp there, cause a UTI, the urinary tract infection in the bladder, and it could easily crawl up the the ureters. And now you're going to have, you just don't want it to go into the kidneys, all right, because that'll decrease the function of the kidney. So what I'm saying is, in pregnancy, it's very common to see urinary tract infections because there's a lot of stasis, a lot of non-movement of that urine, and the bacteria love to swim in that stuff. So just keep in mind, again, this is all pathophysiology. Just keep in mind what progesterone will do, what estrogen will do, because it can start diseases. We see a lot of, I would say there's three types of people out there. There's the male, there's the female, and then there's a pregnant female. There's a whole bunch of things for 9 months that they're more prone of getting that the regular non-pregnant woman actually gets. All right, so when we get into that in a couple of weeks, we'll go into that. Okay, so basically, if you increase progesterone, then that gallbladder is not going to squeeze as much. So therefore, there's going to be a lot of stasis, a lot of stagnant bile that's going to sit in that gallbladder. And if it sits there for a long time, it could change and solidify and become gallstones. All right, you see a lot of gallstones during pregnancy. All right, so those are some risk factors over here. Pathogenesis. So what's happening here is that when the bile gets too concentrated, it sits in there for a long time. Then this liquid bile is going to start solidifying, and we call it sludge. So it turns into this thicker stuff, almost like a pudding. And if it sits there for a long time, it's going to start crystallizing, right? A lot of cholesterol in there. If it crystallizes, it'll start forming stones. And that's what happens, okay? So the gallstone can get lodged in the bile duct. So let me show you what's going on here. I'm going to draw a very quick picture. So we have the gallbladder here. Here's our bile duct from the liver, and this is going to go down into the duodenum. So we have, so here's our gallbladder, okay? The bile duct that came from the liver, which is all here. Common bile duct is over here, and then we're going to have, let's see if I can draw this. So here's our gallbladder, all right? Remember, gallbladder stores bile. That's all it does, it stores bile. The liver makes the bile. So the liver's going to make a lot of bile, but it's not going to just put it right into the duodenum. Here's our stomach. This is the duodenum. This duodenum is only 10 inches long. It's the first part of the small intestines. The 23 feet that come out of here is going to be the other parts of the small intestine where absorption is going to happen, and digestion for that matter. But we got to get bile. Remember, bile emulsifies fats. It starts breaking down the fats into smaller products so that it's better for it to be digested. So what happens here is that the bile comes through here and enter the small intestines. Food is going to come here, go through the duodenum. When it gets in this area, the stomach already, or the gallbladder already knows that there's going to be food over there. It gets these hormones come out of here and also in the pancreas. So the hormones are going to go out and say, all right, you got a fatty meal, because that's what bile is going to do. It's going to break up a fatty meal, McDonald's, that kind of stuff. So if you have a fatty meal, it's going to squeeze the gallbladder to push bile into here, because as the food goes in here, now we can start breaking it up. Does that make sense? Can you visualize that? Let me know if I'm losing you on this, because this is all what we're going to be talking about. Okay? Now, what's going to happen here, and I also want to mention this too, and we'll get back to this. This is where the pancreas is. All right, the pancreas is underneath the stomach. All right, this is really drawing the scale. The stomach should be closer here, but that's all right. So we also have the pancreatic duct that is going to share the same duct over here with the bile duct. Does that make sense? So it's going to share this area. When we get back to when we talk about the pancreas and the diseases, that this is all going to come into play. So what I want to say is, if you have gallstones over here, they're fine. Most people, you and I, have gallstones and don't even know about it. All right? Most people have it. They don't cause much problems because they're small. But if one gets really big, it can lodge here. And now when you have a fatty meal coming in here, this thing is going to squeeze to get bile into here so we can break it up, but it can't because something's lodged right there at this is called the cystic duct, the opening over here. So now it's going to squeeze against something and can't go. That's going to cause pain because the bile can't go there. So look at the pain you're going to get. You're going to have pain. Someone comes to the emergency room and says, I got pain in my belly. Okay, where's the pain? Oh, it's right here. And usually they would say it's in the upper right quadrant. And say, well, is there anything that makes the pain worse? When I eat. Okay, when you eat what, salads? No, when I go to McDonald's. Oh, fatty foods. You see, you're narrowing it down to what's going on. You could say, well, does anything make the pain better? Well, and maybe this is another situation. Yeah, when I eat food, it goes better. Well, then you're thinking of a peptic ulcer. Because the peptic ulcer is going to put out hydrochloric acid in the stomach whenever there's, well, if there's no food there. But when you have food going in there, instead of the hydrochloric acid eating away at your stomach, it's not going to eat away at the food, so the pain goes away. You've got to think of the pathophysiology, why these are happening. That's why I say, don't memorize this, memorize and understand the pathophysiology. But the signs and symptoms, most of the time, if you know the pathophysiology, you could guess all the signs and symptoms. Okay? So that's what happens when it gets lodged over here. This squeezes against something where you can't push anything, and it causes pain. Right? So that's what that is. So, like I said, most of the time, it's asymptomatic. You probably all have gallstones in there, little ones. They're the size of, smaller than a pea. You have them in there, but most people don't have issues with it. Okay? You get this biliary colic. That's that squeezing against something that's not pushing the bile there. They usually get severe pain, usually after a fatty meal in the right upper quadrant. Okay? Questions on that? All right. So treatment is avoid fatty foods. All right. Be careful. When you eat a salad, there's no fat in there. I understand that. But the dressing does. All right. Caesar's dressing, okay. But that's where the fat is. You put some cheese on it. There's fat in there. Okay. I mean, the dressing that if you have, let's say, gallstones, the dressing to choose is balsamic vinegar, right? There's no fat in there. So that's what I'm saying. You've got to be careful with, the foods that you're eating with this. Again, nursing, 50% of nursing is patient education, all right? If it's just so severe, no matter what, the foods that you're eating is just so severe, then they'll do surgery and remove the gallbladder. Your liver still makes bile, so you can still break down the fatty foods. But there's no gallbladder. So the liver makes the bile, but they don't store the bile. So as soon as food comes in there, the liver is going to release, hopefully enough to break down the foods. But you have no storage of it. Okay? Does that make sense? So as soon as it makes it, the liver makes it, it goes right into the water. Okay. So that's what a gallbladder looks like with gallstones using an ultrasound. The ultrasound is the image of choice when we're trying to rule out a gallbladder with gallstones. Now, normally you should see black areas over here, the whole thing, but it's kind of muddy over here. When you see white stuff there, that's something that's blocking the penetration of an ultrasound. Okay, it's not going through there. So they do this, and then they remove the gallbladder, they open it up, and it looks like that. Okay? This is loaded with gallstones. Now, that's not a gallstone. I think that's more like a bubble that's in there. I think it's just the way that, like a soapy bubble. But that's a lot of gallstones. And that's what, you can see that they're not just going to stay away from fatty foods. That's pretty severe. They had to remove that. Okay? Questions on that? And a lot of times they can do this through a little scope, little incision over, maybe 2 incisions, and they could probably do this like same-day surgery. And surgeries are getting easier, more affordable, and less mortality. Okay, so questions on gallbladder or gallstones? All right. The only other one I want you to know for gallbladder is cholecytitis, which is just an inflamed gallbladder. Okay? Inflammation of the gallbladder, the most common cause is gallstone disease, about 90% of cases. And like I said, it's just being pulled. If this is so severe that it's over here, this is going to try and squeeze and cause pain. It's going to, the wall of this is going to get inflamed because of all the trauma it's trying to do that. So that's what's happening. So just keep in mind, and inflammation does not mean infection, okay? But it can lead to infection, all right? The infection might happen a little bit later, but not all the time, all right? We have acute cholecystitis. The gallbladder is enlarged, inflamed, and may start becoming pus-like if there's actually an infection that does happen. Usually mild cases, they resolve in about a week or so. But more severe cases, like 25% of cases, they need to get some surgery and just remove the gallbladder. Okay? We also have chronic cholecystitis, and that's when you have many episodes of acute cholecystitis over like a year or two. Complications is that as it keeps on pushing, you're putting a lot of pressure in there, it can actually backfire and perforate the gallbladder, and now you've got bile that's going to enter the peritoneum and cause peritonitis, which eventually, if it gets infected, it could then go into your bloodstream and get sepsis. Okay? Usually for something like that, you just have to do the surgery and just remove the gallbladder, okay, and clean up whatever the mess was there. All right, so that's gallbladder disease. All done. But these are the pages that would be on the next test. And there's only 3 diseases really to worry about. But these are the pages you should know. Acute pancreatitis. Pretty severe thing over here. 40% are due to gallstones, and 40% are due to alcohol. That's 80% of them. The other 20% is a mishmash of different things, okay? Including, believe it or not, scorpion bites or stings from the stinger. Okay, that can actually cause acute pancreatitis. Certain drugs, trauma, mumps can cause that too, hypercalcemia, and an increase in fats. So here's the pathogenesis on this. For whatever reason is causing this to get inflamed. There could be a gallstone that passes through here, and maybe it's now lodged here. Now, this common bile duct over here, okay, is going to share the pancreatic duct and this over here. So, there's not just the problem of bile is going to be blocked here, but now the pancreas. Now, keep in mind, when we're talking about the pancreas, it's a dual organ. Part of it does endocrine, and that's going to be the insulin and glucagon, right? And it releases those hormones because there's a bloodstream over here, and glucagon and insulin will actually go from here and go directly into the bloodstream. That's how hormones work. But the other part of the pancreas that's an exocrine gland. So it means it's going to produce quite a bit of enzymes. And the enzymes are not going to go into the bloodstream. They need to go into a duct, the pancreatic duct, to be put in here. Now, some of them you should know, these enzymes. Amylase, all right, that breaks down carbohydrates. Lipase, that's going to break down fats. Then you got a whole slew of the carbohydrate ones, all right, not just the amylase. You got the sucrase, you got the lactase, maltase, right? All those things. Remember, if it ends with ASE, it's an enzyme, okay? So look what's going to happen here. If this gets enlarged and food comes down, if this gets blocked, now just look at the whole picture here. Food comes down to the stomach. This is going to send a message to get the gallbladder here to push, right, to get the bile down here. It's a fatty meal. but it's going to be blocked here, so you can get pain here. It's also going to send a message to the pancreas and say, hey, look, we got to get the sugars that are going to go over there. We need amylase there. And if it's a fatty male, the lipase, the bile is going to be coming down here, or need to come down, but the lipase is also going to be needed to break it down too. But you have all sucrase, you have all those enzymes. Now keep in mind, every cell in your body is made up of lipids and carbohydrates, right? And you learn all about that in cytology. The phospholipid bilayer, that's lipids, all right? There's carbohydrates in there too, glucose. So look what's going to happen here. This is telling the pancreas to make and secrete enzymes. But the enzymes can't leave here because there's a blockage. So then what's going to happen is that they're still going to be making more and more enzymes because this is telling it to do that. And what's going to happen is the enzymes, when it gets to a certain level, it's going to start digesting the pancreas. We call that autodigestion. Because it just has so many enzymes here, it's going to eat your own pancreas. Does that make sense? This is why it's bad. And then it's going to get necrotic and start dying and cause bleeding. All right? So you get blockage of the pancreatic duct. It's going to still increase enzyme activity. Okay? You're going to have autodigestion of the pancreas, massive inflammation, and it's all happening acutely. Pancreatic hemorrhage, using up all the blood products. That's why you get DIC, right? Here's a good example of what I'm saying. If you don't know what DIC is, we talked about that, I think, in chapter 6. Go back and understand that now, okay, start studying for that final exam. And can cause necrosis. And again, if you don't know what necrosis is, go back to that other chapter. All right? This is a medical emergency. All right? They're going to have to get that, whatever reason is happening. All right? If you have alcohol that's causing this, well, alcohol is going to make the livers all around here. It could press against this area here. If you got, let's say, cirrhosis, if there's going to be some kind of fatty liver disease, or if there's going to be some kind of cirrhosis that's going to tighten this area, because it's going to get tight and firm, the liver. If you're going to block any of this, if there's anything that's going to block this, it's going to make this expand. That's why I said, I think pathophysiology, the biggest theme is about flow. If it's a back flow or forward flow. I think that's what pathophysiology is all about. Okay? So, questions about that? This is reversible to a point. I mean, once it reaches necrosis, it's not, you can't make things come back to life. Right? Necrosis is dead. But if, let's say, half of this pancreas is all necrotic, we could cut it here, and then whatever's left of the pancreas. That's what I mean is reversible. Okay? Questions about acute pancreatitis. Very important to know. Okay? So I found this in a book. It's basically, step-by-step thing. Do this at home. How the whole thing happens with autodigestion of the pancreas, and why do you get DIC, why do you get peritonitis, shock, and adult respiratory distress syndrome, and so forth. It makes all sense if you follow that. Okay. So signs and symptoms: severe epigastric pain, and what's classic about pancreatitis, they usually say the pain is here, and then if you ask them, does the pain go anywhere? Like if you had a heart attack, the pain usually goes down the left arm. Not all the time. Very rarely should it go the other way. It's just the way the nerves go, and it follows that track. In case with pancreatitis, the pain is here, epigastric pain. They won't say epigastric pain. They'll just point and say it hurts here. And then they'll say, yeah, it goes to my back. It's always that way. It's a referred pain. It just goes back to that way. Okay? But classic. Pain starts in the epigastric area and it radiates to the back. Okay? They get anorexia. They just don't want to eat. A lot of vomiting, nausea. And the thing is, we've talked about this before with myocardial infarctions. When you have ruptures of, let's say, cells, you're going to have a lot more enzymes going out into the bloodstream. What happens here, that's part of it that's going on over here. But because this is making so much enzymes, and it can't go this way, some of them do creep into the bloodstream. Now, normally, there is a little bit that does creep into the bloodstream that you and I have. But there's going to be a massive amount that's going to go into the bloodstream. So whenever we see the words amylase and lipase, and there's an increase in it, think source is pancreas. Okay? Now, I'm not going to lie to you, we have amylase in our saliva too, but that usually doesn't pick up as much. There's salivary amylase and pancreatic amylase. So usually if you want to rule out any diseases that are referred to the pancreas, we need to see the amylase and lipase to see what they're doing on there. Okay? They also get, because of necrosis, they also get hypocalcemia because the calcium kind of gets absorbed by the pancreas because of the necrosis that's going on. So we see that too. All right. The complications: DIC, adult respiratory distress syndrome, hemorrhage, all the things I showed you on the other slide before. It could perforate and go into the cause peritonitis. If peritonitis happens, then it'll actually affect the nerves going to the small intestines, and it's going to decrease the peristalsis of the small intestines. That's why you get this paralytic ileus, right? The peristalsis is not going to go forward, and it can cause sepsis if any infection actually goes into the bloodstream. All right. Treatment is really rest the pancreas. All right. Remember, what's making all these enzymes come out is food going into the stomach. If food goes into the stomach, that's giving a heads up to the pancreas, hey, food is going to be over here, you better get some amylase and lipase into here so that when the food comes in there, you can start breaking it up. Does that make sense? Right? So we have to rest the pancreas. So what do? You tell them you can't eat. They're hospitalized and they're NPO, meaning nothing by mouth. No foods go into here. We got to rest that pancreas. And if there's a gallstone that's over there, then we got to go in and do surgery if we need to. Okay? Does that make sense? All right. So that's acute pancreatitis. Very bad. Okay. Then we have, the prognosis is 20% mortality rate, especially in the elderly. That's why we feel this one. Chronic pancreatitis. Chronic pancreatitis, the most common cause is alcoholism. Okay? About 2/3 of the cases, it's due to that. Gallstones and cystic fibrosis. Why cystic fibrosis? Because remember we talked about cystic fibrosis? It builds more mucus. Like we talked about the trachea. There's more mucus happening in the trachea. And that's why it's a great medium for bacteria to grow, and they usually die of respiratory infections, chronic amount of them. But not just that, we also see that mucus builds up in other areas. Mucus starts building up in the pancreatic duct over here. So when that happens, all the enzymes have no place to go because it's all clogged with mucus. So it starts building up, and that'll cause autodigestion again. All right? So we end up getting fibrosis of the pancreas because the pancreas starts dying down and can't produce any lipase. All right, the lipase seems to be the first one to go on this. They can't produce lipase. Eventually, after months and months of this, the pancreas just burns out because there's so much fibrosis that starts building up over here. There's not much more of the tissue itself to make any enzymes. So usually all the enzymes, they just don't happen. All right, so that's what's going on here. But first, what happens is there's a lot of enzymes that build up just because of the shock of the pancreas of this, and then it just goes down. So signs and symptoms, again, you get epigastric pain that's going to radiate to the back. Very classic, okay? They get steraturia, fatty stools. Why? Why would they get fatty stools? Correct. The lipase is not there, so therefore you're going to have fatty stools. And remember fatty stools, when you flush the toilet, they come right back up, right? That kind of thing. Why would you have night blindness and osteomalacia? Why would you have a decrease of vitamin A and vitamin D? See, it's not about memorization. It's about understanding. No, vitamin A and vitamin D. What types of vitamins are they? Right, they're fat soluble. Right? Remember, the fat soluble enzyme or the fat soluble vitamins are vitamin A, vitamin D, vitamin E, vitamin K. All right? So therefore, you can't, if you can't absorb, you can't break down fat to make these, you're not going to be able to do that. So some people would just say, I'll just memorize night blindness, I'll memorize osteomalacia. Don't. Memorize that you can't make fat, and you need fat-soluble molecules to avoid these. It all comes, that's what I'm saying. Don't memorize the signs and symptoms if you understand the pathophysiology. Does this make sense? Why? Right? Okay. All right. Amylase and lipase usually will go up, but then it'll come back down. All right. It's just because of the shock that happens at first. It's kind of like a fatty liver for alcoholism. It kind of goes. Gigantic liver happens first for a while, and then it just shrinks down to cirrhosis. So it kind of does that kind of thing. Okay. Treatment again. Rest the pancreas. Don't put food inside here because that's going to make the pancreas spit out more of the enzymes. So again, they're nothing by mouth. We could say NPO. All right. If it's the alcohol reason, just abstain from alcohol and supportive measures. All right. This one is a 50% mortality rate in this if it's not treated, and it usually will die within 5 years. Okay. Questions on pancreatitis? All right. The last one on here is pancreatic cancer is what I want you to know about. If you have a mass that's in the pancreas, 95% of them are going to be malignant. Okay? So if the doctor says, you know, we see a mass in there, we got to do a further test, I'm always skeptical. Not skeptical. I'm always saying that's, I don't know if the layman would actually know it, but when doctors and medical professionals hear that there's a mass in the pancreas, we all know that it's not benign. You just don't see benign things. 5%, it's very rare. So if you hear that like something like that, it's usually bad. So the one where you got to deal with is pancreatic adenocarcinoma. It's malignant. This is one of the, probably, I think it's one of the worst or most aggressive cancers that the body has. All right, this is not the one you want. Not that you want cancer, but this is very, very aggressive. Okay, if you have this, usually it's asymptomatic until a late stage. So when you start having symptoms, jaundice, something, it's already well advanced in the cancer stage. Okay, very common. Men are equal to females, mostly in 60 to 80-year-olds. However, this is a disease that celebrities had. Patrick Swayze, right? He had this. And who's the big Apple guy? Yeah, right? Steve Jobs, right? He had a. So even if you have the most money for you know, you have a lot of money, you can't beat pancreatic cancer. It's bad, okay? And they died pretty young. That's why I said 60, 80 years old. It's mostly there, but don't think you're immune to it at, let's say, 40 or 50 years old. I mean, Patrick Swayze and Steve Jobs are both pretty young, okay? So, very poor prognosis. Only 5% of people actually survive after 5 years after diagnosis. Okay, they usually die within 6 months. And it's hard to say about Steve Jobs and Patrick Swayze because a lot of times they hide their diseases and stuff. But if you go back, they died pretty quickly. They died within the year that they actually announced